Good afternoon, everyone. My name is Glenn Keeling, host of HIPECtreatment.com for our HIPEC Facebook Live event entitled Treating Peritoneal Abdominal Cancers with CRS and HIPEC. I'd like to welcome our distinguished guests, Dr. Daniel Abbott and Dr. Nabeel Zafar at the University of Wisconsin Carbone Cancer Center. To start off, I'd like to ask Dr. Abbott and Dr. Zafar to briefly tell us about their HIPEC program and how long they've been offering HIPEC at UW Health.
Thanks, Glenn. So I'm Dan Abbott. I am a surgical oncologist with a primary interest in peritoneal surface malignancies. I am the director of our cytoreductive and HIPEC delivery program. We have been doing cytoreductive surgery and HIPEC for about 10 years at the University of Wisconsin. I arrived there from a previous institution with a mission of expanding our services and providing care for patients with peritoneal surface malignancies. And we have gotten much busier in providing these programs to patients with metastatic colorectal cancer, mesothelioma, ovarian cancer, and even some of the rare kinds of cancers. And we were lucky enough to hire Nabeel Zafar last fall, also trained at MD Anderson, which is where we both received our surgical oncology training. And I'll let him tell you a bit about himself.
Yep, thank you, Glenn, and thank you, Dan. Excited to start at the Carbone Cancer Center here at University of Wisconsin and join Dan in our HIPEC treatment program that we have here, which is pretty robust. And like Dan said, we treat a variety of disease conditions. Nice to meet you all.
Okay. We have a question coming in from our audience. It deals with the localized ocular mucin with LAMN, and what is the wait and watch approach? Can you address that question?
Yeah, so for localized, so I think the question is acellular mucin, and the other important term there is LAM, low-grade appendiceal mucinous neoplasm. And so I do think it's challenging because there is a lot of jargon in this space, and even among experts who deal with this, there is some discussion and discrepancy in what exactly we're talking about. But what there is widespread agreement on is, so a low-grade appendiceal mucinous neoplasm is not necessarily an aggressive cancer that can spread to your liver and lungs, for example. It is more of a localized process that pushes rather than spreads to lymph nodes or to other organs, as I said. And so it's not a traditional quote unquote cancer in that respect, but it certainly is dysregulated growth that pushes on things. The acellular mucin part of that is oftentimes when we have a big ball of mucin, or mucin is just another phrase for jelly, that they don't see the cells that make the jelly. So that mucin comes from somewhere, but we don't always have the ability to tell you exactly where the cells are coming from or identify the cells. And so that can be frustrating because clearly some of these patients have these deposits of mucin or jelly in their abdomen, and we can't tell you exactly where the cells are that they're coming from, but they're coming from somewhere. And so the watch and wait approach would be to say these sorts of tumors tend to grow very slowly, and oftentimes you can have a CT scan, for example, done over a period of 3, 6, 9 months and have little to no growth. And I think one of the really important themes of treatment for this kind of tumor is that sometimes doing surgery is higher risk than just watching it. So surgery is a really big deal, big incisions, removing oftentimes multiple organs, hot chemotherapy, and you have to be very judicious about applying that treatment. And so the watch and wait approach is acknowledging that, yes, there is some tumor inside of my abdomen, but watching it for 3, 6, 9, 12 months or even longer saves someone a big operation and is oftentimes the safer approach. It's I think, emotionally unsettling, but oftentimes does make the most sense.
Okay. We talk about surgery. What is CRS?
Yeah, I can speak a little bit to that as well. And just echoing what Dan was saying about lamins and the disease with the watch and wait process. One thing I did want to add is if it was found after an appendectomy, so if someone underwent an appendectomy and the pathology showed a low-grade appendiceal mucinous neoplasm, people do freak out with the word neoplasm and think it's some kind of really bad cancer and stuff. But if that was the question, that after an appendectomy, is that enough? And we can watch it, that's enough treatment for that. But CRS, let me talk to you a little bit. CRS is cytoreductive surgery. And like Dan said, it involves big incisions and multiple different kind of procedures depending on where the cancer, where the tumors are. There's some things, some parts of the abdominal cavity that we take out routinely. For example, the omentum is kind of fatty tissue that drapes your abdomen from the stomach down. And a lot of cancer cells can be there, even if we don't see them. So we take that out routinely. Then the peritoneum, that is the lining of the abdominal cavity. Sometimes tumor cells stick there. So we take out parts of that or all of that, depending on the tumor. And then the cytoreductive surgery, it says we look everywhere, take out tumor where we can find it floating about, but we can also resect a lot of organs. And oftentimes, if spleen, gallbladder, liver surface, parts of small bowel, parts of large bowel are commonly taken with this operation. If need be, then other organs like ovaries, ureter. Oh, it's not ureter, uterus, I meant. Yeah.
Typically, what type of cancers are treated with cytoreductive surgery in HIPEC?
So the most common would be for appendiceal neoplasms, whether it's these low-grade mucinous or jelly-producing neoplasms, high-grade, which just indicates that under the microscope they look a little bit more aggressive, high-grade mucinous neoplasms, so Lamens, Hammonds, true appendiceal cancer, colorectal cancer, mesothelioma. We hear a lot about mesothelioma of the lungs that we attribute to asbestos, but there can also be peritoneal or abdominal mesothelioma. I would say those are the most widely adopted disease processes for which we do this kind of surgery. In Eastern countries, they will do HIPEC for gastric cancer. We in the United States have not, on a large scale, been able to reproduce the positive results that are seen there. So outside of a clinical trial, we do not generally do that in the United States. And there are also people interested in pursuing CRS or cytoreductive surgery in HIPEC for pancreas cancer, although that again is purely investigational and just at the very beginning of trials. And then what has been probably most exciting in the last 5 years is evidence that using HIPEC for ovarian cancer improves survival. And so we here at Wisconsin partner with our gynecologic oncologists, and we've developed a fairly sizable program with them for ovarian cancer, where the level of evidence is really highest for that disease process.
Okay. And what patients would be your best candidates? And not only that, when should they contact you about HIPEC?
Yeah, I guess two questions there. Contacting us about HIPEC, I guess a lot of our referrals come from the medical oncologist once we see, or a surgeon that sees cancer in the peritoneal cavity. I think it's prudent to reach out to a surgeon or a center at least that does these operations, and that they can assess whether it's appropriate disease, appropriate patient, appropriate, and all the staging and stuff is appropriate to have that evaluation or not. They are complex decisions, and I think they are best done at high volume centers or centers that do these. In terms of patients, the ideal patient, so we have to satisfy a few criteria. One, the disease has to be limited to the abdominal cavity, the peritoneum. If you have metastatic disease to the bones, to the chest, to the lungs, then they wouldn't benefit from a localized treatment that is cytoreductive surgery and HIPEC, which is treating just disease in the abdominal cavity. So that is a important criteria. Other important one is a patient functional status, or how healthy the patient is. So generally, we would not offer this huge operation and hot chemotherapy to someone who's frail and older with a lot of comorbid conditions. We want to get them through a big operation safely. So those are a few main things that are there. And then we do look at extent of disease. We want to make sure that if we are operating, we can take out all the disease. If we are to offer HIPEC, So extent of disease is important. For example, we can't take out all of the intestine or all of the bowel. So surgery that is going to be incompatible with life would not be the right person to operate on. Those are the main factors there. And then there's some other criteria, that nuances that we evaluate on imaging and conferences.
And I would add two things here, Glenn. So number one, we would like to be involved as early as possible in the care of these patients. It is not uncommon, for example, that we will get called from a surgeon in an operating room 2 hours away, and they incidentally find these tumor deposits or this mucin or jelly and ask us what to do. And almost routinely, our answer is just to stop so that we can ask them to get some tissue so that we can see what it looks like under the microscope, and then have a more multidisciplinary approach. And to that point, I think the second important recognition is that oftentimes these patients are treated with a combination of chemotherapy and surgery. And what is often the discussion, and depends on patient factors like Nabeel said, when their last operation was, what the tumor looks like under the microscope, it is not infrequent that we suggest giving 3 to 6 months of IV chemotherapy first prior to surgery. And sometimes we say, yes, doing surgery now in the next 2 weeks is the most appropriate thing, but that is a very tailored approach. And so we, as the surgeons who typically this is a surgical disease rather than is an IV chemotherapy disease, but that's not to say there's not a space for IV chemotherapy, but we'd like to get involved as early as possible and have a multidisciplinary plan set forth so that either us or the medical oncologists aren't getting involved 6, 9, 12 months, after the diagnosis is made. That's frustrating for everybody.
Another question in from the audience, still concerning LAMN. What is the recurrence rate for LAMM after HIPEC? And let's see here. Many studies say that CRS plus HIPEC is looking aggressive to treat LAMM patients. What is your opinion?
Do you have a thought on that, Nabeel?
Yeah, I guess so. Lamin, like Dr. Abbott did mention earlier, it's one of the lower grade or not so aggressive cancers. So the results after, if someone has peritoneal disease amenable to HIPEC and CRS, and we achieve a good operation, which means we're able to get all the disease out visibly that we can, and do the effective chemotherapy, then the survival is pretty good. The recurrence rate is pretty low with that. I would say maybe I don't like to give out numbers as that, but maybe like less than 3 to 5% in 5 years. I don't know, Dan, if you agree with that. But the other part of the question was, can you remind me again? What was that?
The studies that show it being aggressive to treat. What is your opinion on the aggressiveness of HIPEC to treat LAMN?
Yeah, so that, I guess, points to our earlier question as well. There is some controversy around it, and it depends on the disease. So it is okay to watch these. If it's just an appendix and that's out, then that's fine. If it's just localized, you may or may not want to watch that or do aggressive site reductive surgery. A lot of times we do have this discussion with the patients, and a lot of factors go into that. So I guess the jury is still out what the right approach is, but for lamins, it's slow growing, so we can't wait.
I would add to what Nabeel's saying. I think to add two things. Number one, the recurrence rate is pretty dependent on the original volume of disease. If someone just has very localized disease next to the appendix, then the chance of it coming back is much lower than if someone has the spread of that mucin all over the abdominal cavity, and in which case the chance of that coming back is probably somewhere around the order of 70 to 80% at 5 years, versus someone with limited disease, that chance is more like 20 to 30% at 5 years. And so it can be a huge range that is very dependent on the extent of disease in the first place. I think the second point is, and this is also frustrating for patients, is this is a really rare problem, right? We do not have 50,000 of these patients around where we can do high quality studies like we do in breast cancer or ovarian cancer, where we can say, we have one group of patients that we don't do HIPEC and one group of patients that we do, and have a really clear answer. There have been some studies recently out of Europe that have looked with high quality at using this for colorectal cancer, but for LAMNs, it's oftentimes single center or at best a multi-institutional experience, but not in a randomized, placebo-controlled way. And so we have to understand that the level of evidence to support this practice is not what anybody would like it to be. But we do, as I said, we do have, single institution series from really high volume surgeons who've been doing this for 30 years, Dr. Sugarbaker and more, that suggest that adding HIPEC to cytoreductive surgery for these appendiceal neoplasms does portend a better survival. But we have to be very frank in that the level of evidence to support that is not what we would like.
Another question coming in from the audience: is minimizing scar tissue something that could be controlled by the surgeon?
That is unfortunately not the case. And so if someone could come up with something that eliminates or minimizes scar tissue significantly, they would be a rich human being. The reality is that there are some materials that we think might decrease scar tissue, but you're fighting an uphill battle, because when we add the hot chemotherapy to the resectional procedure, we're often taking out, as Nabeel said, we're taking out omentum and colon and spleen. And the reality is with that, and then adding the hot chemotherapy increases the scar tissue significantly. And there's just no two ways about that. And which is why when we talk about doing repeat cytoreductive surgery in HIPEC, which I believe I saw a question about that earlier, that we certainly do that, but we don't do that every 6 months. The scar tissue that comes from these operations is prohibitive, and it starts to put patients at risk rather than helping them.
Okay, another question coming in. Patient is medical oncologist, is not 100% sure that the patient needs HIPEC. The surgical oncologist says yes, because he had a rupture. They finished 8 sessions of oxaliplatin and oxalata in May. Is it highly recommended to receive HIPEC? Adenocarcinoma of transverse colon.
So good questions here. That's another controversial topic there. What we do in these situations, we have a conversation with the surgeons and oncologists. We want to see whether there was any disease outside the colon that they saw at the time of the initial operation. And then whether what the pathology showed. Did it say disease outside the colon, tumor deposits, that kind of stuff? And then the aggressiveness of the disease under the microscope, signet cells or some kind of bad features or mucinous. And then we kind of assess if there is disease outside, there was disease outside, then that's a different pathway. Then probably we do pursue HIPEC treatments in appropriate patients. But in this situation where there wasn't clear evidence of disease, but a perforated tumor, what we're talking about is prophylactic or preventing disease or doing a HIPEC or before we even have evidence of disease, assuming there's microscopic stuff we can't see around there. There've been certain trials, some of them are ongoing, and the jury's still out on that. And some different centers do different practices. Some would surveil with imaging, maybe even repeat like a laparoscopy, look inside with a camera and see if there's disease or not in a year or two. Other centers would not until disease is visible on imaging and then treat it like that.
And I would, yeah, I totally agree 100% with that. I would also add that tension between different providers is challenging and I'm sure very difficult for patients, but it is a reality. People have their own biases in this disease process. The medical oncologists are frustrated because, as we talked about just a second ago, there is not great evidence to suggest that this is absolutely beneficial. We think that it is, but we don't have perfect evidence. And so the medical oncologists sometimes have a bias against that. But they also recognize that their own chemotherapy, the IV chemotherapy they provide, isn't great for this disease process either. So they're stuck in a bind. And many of us surgeons have our own biases that operating and providing HIPEC does add benefit. And so, as Nabeel said, that is an ongoing debate. I think one note that we probably can all agree on is that the cytoreductive surgery part of it, that is removing the disease that you can see with your eyes and any associated organs, that all of us medical oncologists and surgical oncologists would agree is the most important part of this. And that is what should be prioritized. The HIPEC is a bit of a plus minus depending on the circumstances. And as we said, the data is a little bit unclear about that.
Another question coming in, this is concerning laparoscopic HIPEC. Patient does not have much disease, Had a sigmoid colon tumor removed in February. Colon cancer spread to the peritoneal wall, and they're going to do it laparoscopically. What do you think of that? What do you think of laparoscopic HIPEC?
Yep, that is absolutely a real practice, and in experienced hands, that has been shown to have equivalent outcomes to open HIPEC. I would say two things about that. Number one, we have to be careful that patients really do have limited volume of disease, because sometimes the laparoscopic approach doesn't allow you to see every nook and cranny of the peritoneal cavity, and that has the potential to leave tumor behind. Number two, it is a little bit operator dependent, and you probably ought not go to a place that does one laparoscopic HIPEC every 3 years, but a place rather that does that kind of routinely. And so we certainly have adopted that approach at the University of Wisconsin, but it does have to be the right patient. And I don't know if Nabeel's more recent experience at MD Henderson informs a different opinion, but.
Yeah, I agree with Dr. Abbott for sure. I think the right patient and the right surgeon are in the right place are the key elements there. You have to be very sure that there's limited disease, which is often tough to predict on laparoscopy and CT scan. But sometimes you're right. And if it's someone who has the skills to take a thorough look around and look in all the nooks and crannies, there are still chances that it cannot equate to opening up the abdomen and looking everywhere with your hands, but sometimes that's not necessary. So yeah, that is an option in the experienced hands.
Okay. How do you decide who you can operate on and who you can't?
I think Nabeel highlighted that earlier. It is a multifactorial discussion. If it is an 85-year-old patient in a wheelchair with a bad heart, that is someone that I think we can safely say we would never operate on. And conversely, if the patient is 30 and runs marathons, unless there is disease attached to all the small intestine, we can't get it all out, then we're going to operate on that patient 100% of the time. But it is very individual patient dependent, and it does have, as Nabeel said, it has to do with their comorbidities and oftentimes the characteristics of the tumor itself, how aggressive it looks under the microscope, and whether we ought to pursue chemotherapy prior to surgery.
Okay. What are the complications of the surgery and the side effects of the chemotherapy?
Yeah, so so the complication of surgery, I guess a short answer is it depends on what we all do, because cytoreductive surgery is an umbrella term and we can do a lot of different things, but often we are doing some intestine or bowel resections, we're taking some momentum out, we're giving a big cut, we're giving chemotherapy. So usually you're about 10 to 12 to 14 days in the hospital on average. We progress very slowly with increasing diet. There's a lot of times there's some fatigue going on with that. There's delay in bowel function, delay on your ability to eat and have bowel movements. We kind of have to wait that out. Sometimes those are fairly common. Then complications can be leaks from any kind of connection we make between intestine, and that can lead to infections and abscesses. There can be heart attacks and strokes and blood clots, which are with any big operation or major operation per se. And then you've got things that are related to what you take out. There can be bleeding complications if you're operating around the spleen. Some liver abscesses if you're taking out parts of the liver, which are more rare. In the longer run, it's really the fatigue and tiredness and getting back to a good physical well-being is what holds up. And then appetite is a big thing. Having to eat and swallow, and appetite gets busted up. The benefit of doing HIPEC is that the chemotherapy is localized to the abdomen. And with the idea of that, you don't have too much systemic chemotherapy, so the chemotherapy doesn't go all over the body. So other chemotherapy-related complications like you losing your hair, getting ulcers or throughout the body, that kind of stuff is limited by limiting the chemotherapy to the abdomen itself. But you can have low white counts and get infections and stuff. Those kind of things can happen.
What is recovery like when the patient goes home? Can they eat normal? Can they go back to the normal life? What's life like after HIPEC?
Yeah, to Nabeel's point, it does greatly depend on how much surgery you do. But I would say for someone, the average patient who might have an 8-hour operation that includes the hot chemotherapy, I counsel patients that the reality is they're not going to get back to their previous way of life for 3 to 6 months. That does not mean that those 3 to 6 months are all miserable. Usually it's the first couple of months that are pretty tough. But as Nabeel said, it really impacts, number one, your stamina, and number two, your ability to eat. As you might imagine, bathing your intestines in hot chemotherapy is not met with a lot of enthusiasm, and it is almost universal that patients will feel like they have this underlying nausea or fullness or just cannot eat. And I also counsel patients that it's very common to lose 10, 15, 20 pounds after HIPEC for that reason. That always gets better, but sometimes it does take 3 to 6 months to get better. So it is a long road. You know, that going through this HIPEC is not free, and I don't mean financially free, but there are costs to it.
Do people need chemo after the HIPEC?
That's totally variable. It depends a bit about how much disease we may have left behind at the first operation. Obviously, the goal is to not leave any disease behind, but sometimes that's a reality for technical reasons. And so they'll be on chemotherapy, and some patients will get chemotherapy after surgery if they didn't receive it before. But again, that's a very tailored discussion that happens on an individual basis with each individual patient.
Okay. Can people be cured?
So I think that depends on what your definition of cure is. The unfortunate reality for these cancer patients is that for the rest of their life, they are at risk for this coming back. For some patients who have a small amount of disease and the tumor doesn't look that aggressive under the microscope, they can go 5, 7, 8 years, but the tumor can still come back. And other people who have more aggressive disease will have tumor come back within 6 to 9 or 12 months. And so, I don't know about Dr. Zafar. I really hesitate to use the word cure because I don't really know what that means. Unfortunately, all these cancer patients are at risk for coming back. If you say disease-free at 5 years or 10 years, sure, there are absolutely a sizable proportion of patients who are disease-free at 5 or 10 years, but it can always come back.
Yeah, I agree. I don't like to use the word cure for any kind of cancer, even though it is put out there and we do take curative intent or we're going for a cure, but that's a very vague term. Just like diabetes, high blood pressure, we're not curing any of those diseases. A lot of times cancer is, we're trying to maintain the best quality of life for the longest period of time. In strict definition, some people use 5-year as a cure or something, but yeah, typically we stay away from using the word cure.
Okay. I don't see any more questions coming in from the audience. One last question to you. What should patients be looking for in a HIPEC program? And does it matter, who performs the HIPEC, the cytoreductive surgery in HIPEC?
Yeah, I would say that absolutely matters. And so there are cytoreductive surgery and HIPEC programs popping up all over the country. But the reality is, if you're credentialed by your hospital, it doesn't take anything more than wanting to do it to perform it. But there is a very clear volume outcome relationship in cancer surgery, and especially in this disease process. And you should be asking the surgeon about how many of these operations she or he does per year and how many operations the hospital system does per year. Because the reality is this is a team effort. It's not just the surgeon. It's the nurses in the operating room. It's the perfusionists. It's the nurses taking care of the patients postoperatively. And it is a very unique patient population. And so the volume of the hospital and the health system and the volume of the surgeon is the number one thing that should be asked, in my humble opinion. I don't know if Nabeel has any other opinions about that.
Yeah, I agree with that. I think there are a lot of centers with good expertise and good volume. And I will mention that factor in proximity to your house and stuff. I mean, the number one is definitely you need to be at the right place with the right person. And beyond that, you do need a lot of support from your family and friends during this process. Like Dr. Abbott said, it's a long haul. It's not just the 12 days of hospital stay that you're going to be in, but it's several months worth of recovery.
Okay. All right. There's no more questions coming in. I want to thank the audience for attending, and I most of all want to thank Dr. Abbott and Dr. Zafar for their time in answering the questions tonight. If you would like to get in touch with Dr. Abbott or Dr. Zafar, visit HIPECtreatment.com. view surgeon profiles, and you will be able to arrange for a HIPEC consultation with either Dr. Abbott or Dr. Zafar. Again, thank you for attending tonight, and Dr. Zafar and Dr. Abbott, thank you for your time. Have a good evening.
Thank you very much, Glenn. We appreciate the opportunity.
Yep. Thank you, Glenn. My pleasure.
Okay, bye-bye.
Bye.